Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Justin Lishchynsky, a PGY3 anesthesiology resident here in Saskatoon, Canada, presents on anesthesia considerations surrounding same-day total joint replacements. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
I'm Justin, one of the third-year anesthesia residents here in Saskatoon, and we'll be talking about anesthesia for same-day total joint replacement. So our objectives today, we'll discuss the exclusion criteria for patients for same-day discharge for total joint replacement, and then thus which patients will be included. We'll discuss the common barriers to same-day discharge and how us as anesthetists can help mitigate those barriers. We'll review the literature on axial and regional techniques for same-day discharge total joints, and then just kind of a quick review on all our kind of multimodal analgesia options and maybe which ones are best for same-day discharge patients. So as Dr. B kind of mentioned, there's a big prevalence and a need for joint replacements to be done, not just here, but across Canada. The Canadian Institute for Health Information released a report in 2021-2022 that showed about 58,000 total hips and total knee replacements were done during that time, but they also noted that almost 92,000 surgeries were not performed, and the pandemic was a major cause of that. And then there was a news report in Global and CTV this past June, July that showed that the median wait time for total knee replacements in Saskatchewan was well over a year at 467 days, where the average for the rest of the country and other provinces was around 250. So we were quite a bit behind compared to the rest of the country. And then therefore there's started to be a little bit more of a push for doing some same day total joints and getting more patients through and getting their surgeries done. The trend for same day total joints has increased all across Canada up to kind of 15.6% of all joint replacements done in the country have been done as day surgeries. And this is a big jump from the 0.2% that was done in 2015 and 2016. The last 2 points are just kind of a note on the literature. Same-day discharge is usually referred to patients that are discharged home on the same calendar day as the procedure. So this is usually within 4 to 8 hours at the end of the operation, where outpatient is sometimes referred to discharge within 23 hours after surgery. Some studies differentiate between the two. Some studies just use the terms interchangeably, but just something to note when we talk about the literature in a little bit. This next slide actually was just brought to my attention by Shane, one of my co-residents, that he got this bulletin from the SMA newsletter that was sent out yesterday. So it was kind of good timing that the SHA made this little bulletin, kind of more for patient info, just about reducing the length of stay for total joints and joint replacements in the province. So the benefits, the big one obviously is cost savings. That CIHI report from 2022 reported that the average estimated hospital cost for inpatient surgery was about $12,000, where compared to day surgery was around $9,000. So savings of about $3,000 per day surgery patient done. So this equals cost savings around 32%. The US has similar numbers, anywhere from kind of $3,000 to $7,000 per same day total joint done. This same kind of report from the US projected that if they were able to get up to about 30% of all of their total joints done as day surgery, this would save over $300 to $400 million in their healthcare system. So lots of money that can be saved by getting patients done and not having to admit them to hospital and incur all of the hospital costs with their care. If we look at outcomes, just outpatient versus traditional inpatient surgeries, there's no real difference in complication rates. Reoperation rates are the same at about maybe around 2%. Re-hospital admission or emergency department acute care clinic visits are the same between outpatient versus inpatient surgery. The rate of readmission within 30 days is kind of somewhere from maybe 5 to 8%, and then within 90 days is less than 1%. There was no difference in minor or major complications, with minor complications being like superficial wound infections or suture reactions, UTIs, and like non-operative hematomas, where major complications were the MIs, PEs, DVTs, and like strokes. There's been no difference in functional outcomes when looking at specific hip and knee scores like the Harris hip score, and then no clinically significant difference in pain scores. We'll kind of touch on pain a little bit later in the presentation, but no major differences. One study found that there was maybe a statistically significant difference at post-op day one. But when looking at the data, they used the visual analog scale, and the mean difference was 0.9 on that scale from 1 to 10. But then the authors do report that the minimally clinically important difference for hip replacements is 1.9 on the visual analog scale. So even though it was clinically or statistically significant, it was not thought to be clinically significant. Next, we'll move into the exclusion criteria. So this is from a Canadian Medical Association journal. This is what they've compiled and published as to the exclusion criteria for which patients should not be done as day surgery. They just have absolute and relative contraindications. The absolute ones are kind of your major bleeding risk patients with preoperative bleeding disorders, liver cirrhosis, renal disease greater than stage 2. And then the social was a big one, which if they have the inability to, participate in preoperative counseling. So they say lack of mental capacity or even lack of transport to get them from the hospital is obviously big ones. The relative ones, age, they stated age greater than 80, and this is just based on an American College of Surgeons National Surgical Quality Improvement Program that identified age greater than 80 as an independent risk factor for adverse events or readmission. They had an odds ratio of about 4.16. The other ones are ASA greater than 2, severe OSA, a significant cardiac disease. With that one, they say that, it's obviously patient specific, but a significant cardiac history, like an MI or previous cardiac surgery or stents alone does not seem to increase the risk of adverse events if you obviously select the patient well with regards to intraoperative blood loss minimization, and then perioperative hypotension management is carefully managed during the case for those heart patients. Diabetes, BMI, they had greater than 35. Some mixed results as to whether kind of greater than 35 or greater than 40 should be used as the cutoff. So they just used the lower number as part of their exclusion criteria. And then they had some functional tests. And then again, the lack of social support system from a social standpoint. Here locally in Saskatoon, the criteria that Dr. Lutz and I believe Dr. Vandermeer is the other orthopedic surgeon in town that are starting to do more same-day total joints. This is the criteria that they have come up with. The first 2 points are, the patient must live within 3 hours of an operating facility and have access to a 24-hour healthcare facility. And then the patient, again, must have that good social support, and obviously patient must be motivated to do day surgery. So from my understanding, what they told me was that patients, go to PAC, they get screened, and then this is their kind of screening questionnaire or criteria, I guess, that they use for in PAC. So they say, according to our screening criteria, you may be a candidate to have your surgery done as day surgery. If this is something you might be interested in, no, obviously, then they just proceed as normal and plan to get admitted. And then if yes, that whole blurb is basically that their surgeon will contact them and give them more information about day surgery and what to expect. With regards to specific exclusion criteria, I was just kind of provided this list of everything that we exclude here in Saskatoon. So the age cutoff here was 75, BMI was greater than 40. Again, diagnosis of dementia, cognitive impairment, chronic narcotic use, poorly controlled hypertension, have heart disease, again, including valvular disease. This states if it's untreated, and then an MI in the past 6 months. Other congestive heart diseases, untreated asthma, COPD, chronic bronchitis, and then HOMO2 use, poorly controlled diabetes, strokes, TIAs, and then other blood vessel disease like an aneurysm, bleeding disorders, previous VTE, liver disease, alcohol dependency, kidney disease, and then a history of post-op urinary retention, which I thought was an interesting one, and then immunocompromised muscular dystrophies, and then ICU admission in the past year, or the regular use of mobility aids. So it's my understanding that when a patient shows up to PAC, the PAC team goes through all of this, and if the patient doesn't have any of these exclusion criteria, and is otherwise healthy, then they get asked that question if they would like to consider doing a same-day total joint. And then again is referred back to the surgeon that this is something that the patient's interested in, and then they get more information from their surgeon and ultimately make a decision to be booked as a same-day total joint or not. See, there have been some attempts at making kind of some, risk stratification or risk assessment scores. This one is the outpatient arthroplasty risk assessment score. It looks at these kind of 9 different comorbid areas, but as you can see by the scoring, it's a little bit kind of a funny scoring system. And it was found to be pretty accurate in predicting patients who would be successful at same-day surgery, but poor at predicting those who would not be successful and end up being admitted. So that plus it being time consuming, this outpatient arthroplasty risk assessment score is not really used. And then same thing with this readmission risk assessment tool. It looks at kind of 9 modifiable risk factors. Again, it was good at predicting who would do well with same-day surgery, but not so well at predicting those who would not. So again, this hasn't really been used or is common practice. So next we'll move on to the common barriers to same-day discharge, and then we'll talk about how anesthesia can help with that. We'll kind of touch on each of these as we go throughout the rest of the presentation as well. But the typical post-op protocol, it's nothing, too drastic or different from what you'd expect. Patients are admitted to PACU, and they have to meet the standard kind of PACU discharge criteria, usually using like an Eldredi score or something like that, looking at their level of consciousness, their vitals, their nausea control and pain control, as well as recovery of lower limb function. Once they pass PACU's criteria, then they go back to day surgery, where they're usually assessed by a physiotherapist and have to meet specific therapy milestones before they can go home. I'll go over those in the next slide. There's some common physio criteria that have to be met. And then patients usually get another dose of kind of IV antibiotics before they go home, and even IV or oral TXA. They get their post-op x-rays. And then if they're stable, from a vital standpoint, tolerating PO diet and that sort of thing, then they can go home. So this is kind of an example from literature of some discharge criteria. So the mobility one, they have to transfer from bed to standing and then to a toilet, walk with minimal assistance, so they can use a walker or a cane, but have to be able to walk 100 feet, stair walking if they have those at home, and then understand and be able to do their therapies at home. Hemodynamically stable, we talked about pain controlled on PO meds, voiding well, tolerating PO solid food intake, and then well-controlled nausea, lack of vomiting. And then again, that big one, the discharge to a safe environment with active support. So what are the common barriers to same-day discharge? The literature reports the failure of same-day discharge with having to be admitted at anywhere from kind of 12 to 30%. The common barriers are failure to click physio at anywhere from kind of 25 to 30%. Hypotension was 7 to 20%. Urinary retention up to 17%. Nausea and vomiting at 12%. And uncontrolled pain at 6%. Other ones less common is oversedation, pretty rare, 1%. Patient preference, where the patient decided themselves that they wanted to be admitted after their surgery, was at 7%. And then late case in the day done after 11 a.m. was found to have a risk around 19%. It's found to be associated with an increased odds of around 5.16 doing the case later in the day. So next we'll move on to the neuraxial and regional, which will be the big part of our talk, and then we'll kind of come back and touch on some of the other barriers and anesthesia's role in those. As they're multifactorial, we'll touch on them as we kind of go throughout the talk. If we start with neuraxial versus a GA for inpatient total joints, there's been some good studies looking at this. The 30-day total complication rate for a spinal was about 10.7% versus 12% for a GA. And this was statistically significant. If you adjust for potential confounders, that likelihood of complications for a GA had an odd ratio of 1.1. The 30-day mortality rates are some mixed results. There's some studies that show that with the spinal, the 30-day mortality rate was 0.1% compared to 0.18% for a GA, and this was statistically significant. There's another large meta-analysis that found that there was no difference between the two. Pulmonary compromise, neuraxial had a lower rate of 0.37% versus GA of 0.81, and then cerebrovascular event at 0.07 versus 0.14 for neuraxial and GA. Both of those were statistically significant. In the inpatient group, the length of stay was slightly shorter in the spinal group at 3.45 days versus 3.77 in the GA group. And then spinals also had a lower frequency of superficial wound infections and blood transfusions. So kind of based on all of this, the authors, concluded that neuraxial was preferred to a GA, obviously if appropriate, in the patients. If we look now for same-day discharge, no difference in 30-day major complications. Neuraxial was still lower at 1.8% versus 2.3%. The major complications were like MIs, DVTs, pulmonary embolisms, strokes, and acute renal failure. And then also no major difference in the 30-day minor complication rates, which again were surgical site infections, UTIs, even pneumonias were included in that group. But neuraxial was slightly lower again at 3.3% versus 4.1%. But not surprisingly, there's no major statistical difference between the two because we're usually selecting younger, healthier patients for same-day discharge, and they're most likely going to do well with a neuraxial technique versus a GA anyways. But some of the differences that were found were post-op nausea and vomiting. Again, makes sense. Neuraxial was a little bit lower at 3% versus 4.5%. PACU maximum pain scores were lower in the neuraxial group at kind of 5 out of 10 compared to 7 out of 10. And then length of PACU stay was shorter in the GA group. Again, makes sense. You're not waiting for a spinal to wear off at 136 minutes versus 188 minutes. And then admitted after surgery, the study found that neuraxial was lower at 23% versus 33%. So again, some evidence and kind of a trend that neuraxial, again, may be better than GA for same-day discharge. But again, it's patient-specific and patients do well with both. Next, before we dive into kind of the specific local anesthetics used in same-day surgery, I just kind of wanted to touch on some of the pharmacology and just touch on, when choosing a local anesthetic, what are the properties that we look for? The lipid solubility relates to the potency of the local anesthetic. So the low lipid solubility indicates that higher concentrations are needed to produce the nerve block. And then conversely, obviously, high lipid solubility produces anesthesia at lower concentrations. The protein binding is what affects the duration of the local. So the higher the protein binding, the results in the longer duration of action. The pKa of the local is the pH at which the ionized and non-ionized forms are present in equally in solution. This is important is because it's the non-ionized form is what diffuses across that lipophilic nerve sheath and reaches that sodium channel to exhibit its mechanism of action. And then the onset of action relates to the amount of local available in the base form. So most local anesthetics follow the rule that the lower the pKa, the faster the onset of action, and vice versa. I hope that made sense to everyone. This next slide is from our Miller textbook. Just kind of a summary slide that I included for just for completion, a list of all the kind of local anesthetics that are commonly available, their usual concentrations and usual durations. But we'll go into now some specific studies that looked at the specific locals. The first one is Lido. If you were like me, you're wondering, well, why don't we use Lido for our spinals? It obviously can be used and has been done. 2% isobaric lidocaine was used in this study. They had an average total motor block of about 2.89 hours. Average time in PACU to return to motor function was pretty good at 0.58 hours. And then the average time from admission to PACU ambulation was 3 hours. So all really good if you're looking, for same-day total joints and for same-day surgery. The issue, though, with lidocaine is the transient neurological symptoms, or TNS, which is pain and dysthesias that kind of originate in the lower back, buttocks, and then radiate down into the thighs and into the lower limbs. It usually has an onset of within kind of 24 hours of the spinal, usually, of course, obviously once the spinal wears off. And then these symptoms spontaneously resolve in about 5 to 7 days. This Cochrane meta-analysis said that TNS occurs in about 14% of patients receiving a lidospinal. So then they specifically looked at the risk ratio of comparing Lido to all our other anesthetics. When you compare them to all the others, the Lido had quite a big risk ratio at 7.3, but then when you compare it to the PIV, it was 0.16, where PIV was 0.1, and then mepivacaine was about equal at 1.01. The mepivacaine one we'll touch on in a bit as well, but it's interesting because this is kind of debated in the literature as to the risk of TNS with mepivacaine. There was a retrospective study at a Toronto Western that reported the TNS occurrence at 0.14% with mepivacaine out of the about 650, I think, spinals that they studied, where some other reports in the literature reported around 6%. So then if we look at bupivacaine versus a GA and outcomes of same-day total joints, this study used hyperbaric bupivacaine, so the 0.75%. Their spinal was anywhere from 10.5 to 15 milligrams, depending on patient size and weight. Mepivacaine was 2% mepivacaine, anywhere from 40 to 60 milligrams. The GA group got a pretty standard kind of cocktail of fentanyl, anywhere from 25 to 50 mics. Prior to intubation, they got Lido, intubating dose of propofol. They ran SIBO during the case, but they did get ketamine at kind of 0.5 milligrams per kilo in the GA group, as well as IV Tylenol, and then dexamethasone for analgesia and post-op nausea and vomiting. So if we look at the significant differences here, the minutes to ambulation was significantly shorter in the mepivacaine and the GA group compared to bupivacaine. As you can see there, mepivacaine and the GA group had basically the same number of minutes to ambulation post-surgery. The minutes to urination were significantly lower in the mepivacaine group, as well as low in the GA group, again, compared to bupivacaine. Post-op nausea and vomiting was highest in the GA group at almost about 50%, where in the spinal groups, they were around 20%. The pain at 1 hour and 2 hours post-surgery was significantly lower in both spinal groups. You can see there where general had about 5 at 1 hour, where the scores were quite low in the spinal groups at 1.5 in both of them, and then the 2 hour scores there as well. And then discharge or pain at discharge was significantly lower in the spinal groups as well compared to the general groups. Not huge numbers, a difference of 0.8 compared to 1.7 is probably not a huge difference when you think about it, but it was statistically significant. And then the last one here is this MME, which is milligram morphine equivalence, basically how much opiate they consumed post-op, was significantly lower in the both spinal groups compared to GA. The next study is this one. They had this nice little infographic that they published that I just inserted here. So this one looked at 3 different spinal options. There, mepivacaine, they used 1.5%, 3.5 mils or 52.5 milligrams. Hyperbaric was 1.5 mils or 11.25 milligrams. And then the isobaric group was 2.5 mils or 12.5 milligrams. Their primary outcome was the time or the percentage of patients within those groups that ambulated within 3 to 3.5 hours. You can see by that middle table there, the mepivacaine group had the greatest proportion at 70%, followed by hyperbaric and isobaric bupivacaine. And then the mepivacaine group had the greatest percentage of patients being able to be discharged on the same day. They do note kind of that next graphic down there with the guy kind of holding his back. They state that the mepivacaine group did ambulate sooner, but they had more pain and consume more opiates post-op. But again, the pain scores were from 0 to 10. The mepivacaine group had an average score of 2 out of 10 compared to 1 out of 10 for the other 2 spinal groups. So then another study looking at mepivacaine versus bupivacaine. The mepivacaine spinals had an earlier return to motor function, 154 minutes versus 170, shorter lengths of stay, 25 versus about 30 hours, decreased urinary retention at 7% versus almost 11%, no difference in pain scores in the study, and then no difference in distance ambulated. So makes sense, mepivacaine a little bit shorter acting anesthetic, that they're going to have earlier return to motor function and sensory block compared to something more long acting like bupivacaine. If we compare then bupivacaine to bupivacaine, the 0.5%, both groups received 17.5 milligrams of either 0.5% bupivacaine or 0.5% bupivacaine. They had the same median time of onset of about 2 minutes, but bupivacaine had a little wider range at 2 to 9 minutes. The median duration to sensory block at that T10 level was shorter in the bupivacaine group versus the bupivacaine group, 3 hours versus 3.5. And then the median duration of their complete motor block was shorter in the ropivacaine group at 2.1 hours versus 3.9 hours. And another study, again, comparing ropivacaine versus bupivacaine. This study, the patients received either 10 to 12.5 milligrams of either the 0.5% ropivacaine or 0.5% bupivacaine. There we go. The time to first ambulation was significantly shorter again in the ropivacaine group, 11.2 hours versus 12.9. That was kind of their main statistically significant difference that they found. Other differences, though, there we are. Total distance ambulated was not statistically different, but they actually found that the bupivacaine group was able to ambulate further. And then the EDD in this study was morphine equivalence daily dose. So again, just a measure of post-op opiate consumption, not statistically significant between the two or different between the two groups, but the ropivacaine group may have had a little bit lower opiate consumption. Then one last study here. This one compared bupivacaine versus ropivacaine. Bupivacaine was 1.5%. They used about 3 to 4 mils, and the ropivacaine was isobaric again at 0.5%, 2.3 to 2.7 mils. This study found no statistically significant difference in the discharge time between the two groups. But as you can see by their numbers, they had small numbers in the study and not even equal numbers between the two studies. So those results can be kind of taken, I guess, with a grain of salt. So that's it for kind of the studies that examined the difference between our different local anesthetics commonly used for spinals in total joints. If we look at opiate use for the spinals, the common ones that are reported in literature are morphine and fentanyl. Morphine, as we know, has a slow onset of action. It usually takes effect greater than 30 minutes, but it has a long duration of action that it can last for greater than 24 hours, and thus is a risk for delayed respiratory depression if you get some cephalad spread within the CSF of that morphine. And then it has the significant side effects of pruritus, nausea, vomiting, and urinary retention, all the things we don't want in general, but especially, if we are going to be same-day discharging these patients. So morphine, I know we don't really use anymore for, or epimorph for our spinals and total joints, even for the patients that are being admitted. Fentanyl, more lipophilic opiate. They showed that it has a minimal respiratory depression if doses are less than 25 mics. Its use in same-day total joints is questioned. All the studies that I just kind of presented, none of them mentioned anything about using opiates in their spinals for same-day total joints. But there is some, good evidence that shows that it does not lengthen the duration until discharge in ambulatory surgery, but those weren't specific to same-day total joints. So I wasn't able to find any studies that mentioned or looked at, I guess, the use of fentanyl, even sufentanil, for same-day total joints. Next, if we move on to our nerve blocks, we'll just kind of quickly cover the femoral nerve block. When comparing it to the adductor canal block, as we all know, it has a significant reduction in patient strength and then thus ability to do physio and mobilize post-op. So as I mentioned, when compared to adductor canal blocks, it had a reduction in quadricep strength by about 49%. They had a slower timed up and go test by 20 seconds, which is a test of just how long it takes for a person to stand up from a chair, walk a distance of 3 meters, and then come back and return to sitting in that chair. And then patients also had a reduction in balance scores of about 56%. So all things, obviously, that we don't want post-op, even for, I guess, our admitted patients usually. But there was no difference in pain scores at 4, 24, and 48 hours between the two groups, even though the femoral nerve block is traditionally thought as the gold standard for pain control post-op in total knees. But again, should be not really recommended or used unless patients have chronic pain or pain issues, but that are likely to be admitted anyways for pain control post-op. So then if we move to the adductor canal block, more commonly used where you're targeting that saphenous nerve, as it has some terminal sensory branches from the femoral nerve. It supplies that innervation to the medial aspect of the leg down to the ankle and foot, and then also actually has some infrapatellar branches to the knee joint. So it's also to be noted, I guess, that's become maybe a little bit more popular in the literature. There's not a ton of studies on it, but an important one to note is that nerve to vastus medialis, or NVM, at that bottom picture. I apologize that it's flipped compared to the top picture. But this is an important nerve that's thought that should be targeted as well for analgesia. It was initially thought that when you're doing an adductor canal block, that nerve to vastus medialis would be covered with the spread in the adductor canal, but when they did cadaver studies and that fascial kind of tunnel is open, they found that nerve to vastus medialis is in its own separate, entirely separate, fascial layer and tunnel. So some studies kind of talked about targeting that nerve specifically by redirecting your needle through another fascial layer that you may or may not feel a pop through, and targeting that nerve to vastus medialis. There was the caveat, though, that because you're targeting a nerve that specifically targets that vastus medialis muscle, that it's theorized that it could contribute to some muscle weakness, but I wasn't able to find any research that specifically mentioned or looked at that specifically. So when you compare the adductor canal block to placebo or no block, the adductor canal block had lower pain scores at rest and with movement, and then patients had less narcotic consumption by kind of almost 12, 13 milligrams. So it is an effective block. When we look at the choice of local anesthetic, ropivacaine and bupivacaine are the most common for our longer acting blocks. All variations of ropivacaine have been studied, 0.2, 0.5, and 0.7% have all been used effectively. Same with bupivacaine, 0.25 and 0.5%. And then comparing the two isobaric or 0.5% bupivacaine versus ropivacaine for the adductor canal block, there was no statistically significant difference in pain scores at 24, 48, and 72 hours. The only thing to mention, I guess, is just that ropivacaine has a greater sensory to motor selectivity, and then is less cardiotoxic. So is usually the choice just for those reasons compared to bupivacaine. For the volume of anesthetic, there's been some MRI and cadaver studies that show that volumes of 30 mils and above resulted in some proximal spread up into the femoral triangle, and thus getting some more motor weakness. So the ED95 was about 20 mils, which was shown to be adequate to fill the adductor canal. So that's 20 mils was able to fill the adductor canal in 95% of patients in this study. And then in that study, they noted that there's maybe about an 8% reduction in quadriceps strength compared to placebo when you're injecting 20 mils of fluid into the adductor canal. But this is not thought to be clinically significant, as actually most people have a 10% difference between their two legs with regards to quadriceps strength. So then this is just not thought to be functionally important. One last block, a little newer one, is the IPAC, which is the infiltration between the popliteal artery and capsule of the knee. So this is a motor-sparing block that targets the articular branches of the sciatic and obturator nerves, and then thus provides analgesia to the posterior section of the knee, and then is motor-sparing as you're not targeting the motor branches of the tibial and common nerves, which we commonly do with the popliteal sciatic block, which is a little bit more distal in location, or you're performing the block a little more distal in location for foot and ankle surgeries. So when we compare the IPAC versus the adductor canal block, or with the adductor canal block versus the adductor canal block alone, makes sense that you're going to have lower pain scores at 12 and 24 hours at rest and with mobility, and then greater reduction in morphine equivalents as you're just targeting more nerves and getting more of that posterior capsule and posterior part of the knee that isn't adequately covered sometimes with the adductor canal block. However, though, when you look at the IPAC plus the adductor canal block plus a periarticular block that the surgeons do, there was no difference versus the adductor canal block and the periarticular block. But again, this is a newer block. There wasn't a ton of studies on it, and could be a good option for some patients. But again, it's another block you have to do. It's time consuming. And we all know orthopedic surgeons don't really care too much, right, about time and OR flow. So not commonly used for same-day total joints when you're trying to get through as many patients as possible. Next, if we move on to some adjuncts that are reported in the literature, dexamethasone is one. that has been studied. The mechanism of action is kind of multi. It's proposed that it provides inhibition of the potassium channel mediated discharge from some of those C fibers, as well as attenuated release of inflammatory markers. If it's injected perinaturally with your local, it increases the duration of analgesia by about 4 hours when using with shorter medium acting locals, and then up to 8 hours when you're using your long acting ones like bupivacaine and ropivacaine. It does though also increase the motor blockade by 2.5 hours, and for short acting or medium acting locals, and then increases the motor blockade by 4 hours with our longer acting one. But when you compare it to IV versus a perineural injection, both do prolong the block compared to placebo. Placebo was 12 hours and then up to 20 hours for IV and 22 hours for perineural. So not a huge difference between the two. It was shown to have no difference in pain scores or opiate consumption at 24 hours. And then there is also the well-documented benefits for post-op nausea and vomiting in the IV group. Therefore, IV is more commonly used instead of adding it to your nerve block. Our alpha agonist clonidine and dexmedetomidine can also be added. They both increase the duration of analgesia. Clonidine by 2 hours, the sensory block by 1.25, and the motor block by 2.5 hours. But it does have increased probability of the kind of unwanted side effects of hypotension with an odds ratio of 3.6, fainting at an odds ratio of 5, and sedation and bradycardia there as well. Dexmedetomidine, a little bit better in increasing the duration of our block for analgesia, about 4.5 hours, sensory block at 4, and motor block at 3 hours. But again, has some side effects from systemic absorption of bradycardia and sedation, things again that are therefore not commonly used for outpatient total joints. Epi also has been studied for its vasoconstrictive effects and just increasing the duration of local present in your block, or in the location that you injected in your block. It's only been shown to increase the duration of analgesia by about 1 hour, but it can be used as a marker of intravascular injection where you get those side effects of tachycardia and hypertension. I guess not necessarily side effects if that's what you're looking for. Opiates have been studied in nerve blocks as well, fentanyl and morphine. There's some kind of conflicting evidence to how effective it is in a nerve block. And then it hasn't been shown to be any superior over systemic or IV use, and therefore is not really used too much. Buprenorphine has been studied as well as our partial mu opiate receptor agonist, and then kappa opiate receptor antagonist. It's been shown to increase the duration of analgesia by about 8.5 hours, but does have some side effects of increased risk of post-op nausea, vomiting, and pruritus. And thus, again, isn't commonly used, but can be used for those more chronic pain patients. Next, if we look at the periarticular injection or a local infiltrative analgesia, this is a large volume block. That volumes have been reported up to like 80 to 120 mils in the literature. It's injected, kind of around both the hip and the knee, trying to target different kind of tissue layers and, the joint capsule, and then like things like the soft tissues all around the knee. There's significant variability in the cocktail used. Most use a longer acting local anesthetic like ropivacaine and bupivacaine. So then we just have to be cognizant of the toxic doses, especially if we're doing a nerve block ourselves. NSAIDs are sometimes added, usually ketorolac. Opiates sometimes as well can be added, as there's actually been some opiate receptors around the knee. Morphine and tramadol, little longer acting ones, have been used. Corticosteroids like methylprednisolone and dexamethasone for their pain effects as well as anti-inflammatory effects. There's been some talking literature about concern for risk of joint infection with steroids around the knee, but I didn't find any conclusive evidence one way or the other. Epi, again, for that local vasoconstriction, and then our alpha drugs of clonidine and dexmedetomidine have been used as well. Dr. Luch was kind enough to share with me his field block that he uses down at the bottom right there of that 5% or 0.5% ropivacaine. He uses a total of 40 mils. He adds ketorolac to his, and then adds epi, 0.3 mils there of the 1 in 1,000 concentration. So if we compare the periarticular injection to our adductor canal block, a meta-analysis actually found there was no statistically significant difference in pain at 24, 48 hours with rest or ambulation between the two. Same with no statistically significant difference with opiate consumption and length of stay. And they found that actually the periarticular group had a better timed up and go test and distance walked at 24 hours. However, when you combine the two, the periarticular injection and the adductor canal block, it does significantly reduce post-op pain scores and opiate consumption. So combining the two is better than using either one alone. Okay, so now we'll kind of just touch on some of the multimodal analgesia options for joint replacement. This isn't, anything that I don't think will be new to most people. The American and European Society guideline or released the joint guidelines for some kind of practice pathway options for this was specifically to total knees, but they said they extrapolated and could be used for total hips as well. Acetaminophen or Tylenol, it has long-standing supportive data for use in multimodal analgesia for almost every patient because it's predictably efficacious, has a favorable safety profile with relatively few side effects. They've looked at the difference between IV and PO and found that there's really no clinically significant difference. And then especially given how expensive the IV formulation is, that PO pre-op is just as good. NSAIDs, our COX-2 inhibitors are a little bit better than the non-selective NSAIDs for risk of GI bleeding and ulcers. So celecoxib is more commonly used than say Advil. Again, lots of data that's shown that it improves pain scores and reduces opiate consumption perioperatively. And then actually when you combine Tylenol and Advil, both have a better effect than either drug alone. Gabapentinoids, pregabalin and gabapentin have also been studied with kind of mixed results. Some studies show that it is helpful for post-op pain. Some say no. Some say that it's just better for reducing the risk of developing chronic pain after total joint. So since it has some mixed results, the biggest thing is, kind of the unwanted side effects that you can get from it, of sedation, dizziness, and blurred vision. So this joint guidelines from the European and American societies actually said that they don't support the use of gabapentinoids for same-day surgery. Corticosteroids, we kind of talked about, but perioperative dex has been shown to decrease pain, and then the big effect as well is they're reducing the risk of post-op nausea and vomiting in all surgeries, not just in total joint surgeries. And then, again, no real significant difference in the rate of periprosthetic joint infections and should be used pretty regularly in kind of almost all patients coming for total joint surgery. Ketamine or NMDA antagonist has been studied as well. It has lots of evidence for its analgesic effects, that it decreases pain scores and opiate consumption up to 48 hours post-op. As long as you keep the doses less than 1 milligram per kilo to limit those psychomimetic effects. But there were no studies that looked at it specifically in total joints itself, other than that one that used it as part of a GA, but nothing comparing the use of ketamine versus not for post-op pain control. But it makes sense that it would be used, or that it could be used for analgesia purposes. Same with dexmedetomidine. If you use lower doses, it's been shown to reduce pain, post-op nausea, and vomiting, and delirium. But it does significantly prolong the spinal, 220 minutes versus 131 minutes versus placebo. So quite a long prolongation of your spinal, which is not always wanted, especially in same-day total joints, and then does have some side effects of bradycardia and hypotension as well. So if we just go back to, some of the common barriers to same-day discharge, these are pretty multifactorial. We talked about the regional and neuraxial meds and how they can be used for this. If we go into hypotension, we talked about spinal dosages a little bit. Blood loss is the other one, and trying to minimize that. TXA has been studied pretty extensively and shown to have good evidence at reducing blood loss by 300 to 430 mils and reducing transfusion requirements. There was no clear benefit in the formulation of PO versus IV. And therefore, IV is usually just recommended at typical doses of kind of 10 to 15 milligrams per kilogram prior to incision. I feel like here in Saskatoon, almost every patient gets TXA with their total joints. IV fluids, there's no real good evidence as to how much IV fluids these patients should be getting. I know kind of people thought was everyone should get 1 liter or 2 liters of Ringers with their total joint. But the thought is, I guess it should be more tailored to blood loss, which is also sometimes hard to estimate and gauge. So there's limited evidence on the optimal fluid strategy and should be, as best you can, goal-directed or patient-directed as well. Urinary retention, a big one as well that sometimes delays people's discharge. I know also an issue sometimes for our inpatients as well. The things that the report recommends is just avoidance of that intrathecal morphine. As we talked about, fentanyl and sufentanil are debated as to whether they should be used in these same-day total joints. And then IV fluid management plays into that as well, which we just talked about. And it's hard to know the optimal amount of fluid these patients should be getting from a hypovolemia standpoint versus a urinary retention standpoint. And then the last big one was the risk of post-op nausea and vomiting, which, like most surgeries, they just recommend dual antiemetics of dexamethasone and Zofran for these patients.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.